I was delighted to give this lecture today because it is something I've been interested in, have actually published on it, and actually have lived through it, as I did train in the 80s. So we will reveal that, where we were every other night when I was a resident at UCLA. Work-life balance, hours worked, it was more a badge of courage for those of us in my generation. That kind of training led to being a better surgeon at that time. And so that gets along to cases done, responsibility, and we'll talk a bit about that today, because part of this is learning not only to do the procedures, as many of you know, but also having some autonomy in that you actually feel you could do them alone if forced. And that was one of the things that really was a gradual increase in training. Since I was a department chair, all that has changed. A lot of it is good. Some of it is worrisome for those that teach and train. And so today we're going to talk a bit about what it is to be a professional, what have the work hours done, because it's part of our culture now. It's what we do most everywhere. I have visited a couple places where it's not so much, but probably 98% of departments are really embracing the work hours. And then looking at something called burnout, which actually has some correlation to being fatigued, but has more relation to how you spend your day every day, and making sure you end up in a spot that you love your job. Because if you talk to the best physicians, surgeons, or people you know, they love their job. Even if they've been doing it 5 years, 20 years, 50 years, you see their energy and their passion. And if you were ever to aspire to do anything, is to maintain that passion for what you do throughout your career. So I have no relevant financial relationships. So professionalism, I think that's the biggest piece that I want to emphasize, is that we are professionals. It's not an occupation. We don't have a job. We actually are a profession. People are depending on us to take great care of them with good qualities of ourselves, and also making sure that we're capable of doing it. And the definition I like to use is the upholding by individuals of the principles, law, and ethics and conventions of their profession. So this is very broad, but goes to show that you are here not only to get yourself educated, to be someone that's a great doctor. You owe it to your patients, you owe it to your students, and you have many things that you do that are upholding these laws and principles. So Alan Norton wrote about this. What 10 things define professionalism? Maybe not necessarily in physicians, because he was talking about everyone, but you put the patients or your customers first. That's the first one. And this whole patient-centered care is so important. And I've been quoted as saying my career is really initially was all Julie-centered. When can I be in the OR? When can I make it to clinic? When can I see the patient? We're really flipping that now, that it's really when is the patient need to be seen? What does the patient want? And that's so important, especially if you've ever been a patient, that you really need to be put first. You need to make your expertise your specialty. So whatever you're good at, that's what you should be doing. You should not be doing something you're not good at. Students are struggling with that right now as far as what am I good at? What do I like? That's your specialty. You always do more than expected. Professionals never have to be asked to finish it up or make it happen or worry about it. I say that most of us, what differentiates us from people that perhaps don't do operations or intervene, is we fret so much, don't we? We fret about someone we just operated on. We fret about someone in labor. We fret about someone with an aneurysm. And you do more than expected all the time. That's what we do as professionals. And you do what you say, and you say what you do. You're true to your word. There's nothing worse than having a partner or someone on with you, as you know, without integrity, and they don't do what they say they did. The example I'll give is when I was an intern, there were two of us every other night, and every day we had to read out the labs. And this is going to shock you. We did not have computers, so we had to go into the basement, write all the lab values on a little card, bring them up. It took an hour and a half a day. It was amazing. And my partner, Warren, would come up and read all the lab values out. He'd go home that night, and they were all wrong. He never went down there. He sort of dry labbed it. And I was like, okay, Warren, I said, you can say whatever you want in front of faculty to look good, but tell me the truth. So years later, when he invented something, I wasn't sure it was really that good, because I had seen him where he made up stuff. So part of it is you do what you say and say what you do. And then you have to communicate effectively. We've made it very clear that errors that occur in the hospital are 80–90% due to lack of communication, either whether it's in the OR, the ED, through your patient or whatever. So becoming a superb communicator is so much part of being a professional. You have to follow exceptional guiding principles. You always go to that North Star. You always do the right thing, always. You praise your peers and not yourself. That's tough for some of us, isn't it, to do it? But you need to learn to do that because that's your favorite person, isn't it? The one that always is telling you what's great about the people in your group, your team, whatever. That's what a professional does. You share your knowledge. You don't keep things to yourself. You make sure that everyone knows, unlike Warren, who knew those lab values weren't right. And you say thank you all the time. You need to thank the people that work with you. You need to thank the patients for being there to let you learn to be a doctor. And then you need to keep a smile on your face and the right attitude in your heart. If you are a leader and you walk around looking distraught or you look like the world is falling apart, people are going to think it actually is. So you'll never see me do that. I will always look fine. You always see me fine, just like this. Back in the office, not so fine, but out here, fine. And you need to make sure you always have that right attitude because everyone's watching you. Last week, I got my California license plate. I had 2 people come ask me, where's your car? Because they noticed my license plate, which did say Golfer 7, which many of you probably noticed from Maryland, was gone. So people watch everything when you're a leader. So always have that best attitude. And in his book, this is one of his quotes, you don't have to look any further than the medical profession to see examples of true professionals. Think back upon those doctors you've liked the most and model your professionalism after theirs. That's who you want to be. And that's what we're going to talk about today. So what did those 2003 rules do? I mean, one, it woke us all up. I arrived at Hopkins in 2003, and the entire institution thought this was my idea, that I showed up with 80-hour work week, because we really didn't start doing that till about 10 years ago. And these are some summary slides, just looking at papers that are out there saying, is it positive or negative? And for resident education, cases was a big deal. And it does appear that most of us have figured out how to get enough cases and procedures. So when you're here, you're very intense doing that. Some maybe not so much. And there has been some in surgical literature, maybe as an intern, not so much with the new rules. Examination performance looks pretty positive or neutral. There was some issue with the general surgery exam that perhaps the oral exam, the results weren't so good. But we actually probably were asking the wrong questions, and so I think that's probably good. And other effects, maybe a few negative things, but not so much. There's no question quality of life is much better because you're actually able to focus yourself. You have a day off. You can count on being gone. When I was there were days I didn't get home as an intern. My parents visited once, and I didn't get home for 5 days. So that's where we started, and even though we tell you that's the way it to be, a lot of people fell off the truck back then, for many reasons we'll talk about. So it is much better for that. And we're going to talk a bit about burnout today because that's something you need to recognize, but it does appear that that's better too. So what about faculty? That might be a little different because the faculty have actually had to reorient themselves because things that residents used to do and similar things that medical students used to do are different now. And we just have to reframe it because when students are on your service, there's many things they can't do, but they can do other things. And residents also can do other things. So workload, maybe 50-50. Some young faculty tell me that they're the ones, finishing up things at night. They're the ones that are rounded by themselves. They're the ones that were banking on making sure when they became faculty that the resident would do all of this. So as 10 years have gone by, it's so much better. As you can imagine, back in 2003, the faculty are, what is this? But as you can see, there are quite a few negative things out there about job satisfaction, worried about resident, worried about continuity of care and quality of life, and the faculty to do that. So I think we have done some things to make that better. So when you look at the whole business, why did we do this? Part of it was education. It was we needed to get the work of the hospital off the back of the resident and teach them how to be a great doctor. Now, some of that is service. I mean, you do need to have to put in a Foley. You need to know how to draw blood. You need to know how to intubate somebody. You need to do some of those things yourself. However, we spent a lot of time going down and writing labs on cards, pushing people through the hospital, which sometimes you'll do because someone's sick. I mean, you'll be a professional and take care of it. But if you look at the educational hours, educational day, lectures, things that we do, it's so much better. It used to be follow me around and you'll learn everything you need to be. Okay, just follow me, I'll Velcro here, I'll show you everything. Now you can't spend 120 hours with me doing that. So we're going to focus you, and I actually think the educational piece is so much better. So generations, and this is what's interesting, along with these hours, the generations have changed. And as we sit here, I'm sort of a baby boomer person. I was born in 55. When you look at some of our senior faculty, they're really from this veterans, where very regimented, change of command. That's where I was trained. That's where I came. It's very clear where I was. Low on the totem pole, nothing. Okay, and they reminded of that all the time. We accepted it. Life was good. We actually sort of came as being more optimistic instead of loyal as our baby boomers, and we really had ability to change command and share. Generation X sort of drove us a little crazy in the sense that they were much more skeptical of life, brought things to us in our face. It actually was really good for us to think about work-life balance, since we had never said that word before. And they also had short-term employment. They had many things they wanted to do. And I have two stepkids that sort of sit in this piece, and they're very different, and they're in charge. They tell me what to do. Now, the millennials, we like a little better, okay? I have an 18-year-old, and he sits in this mainly because they're the collaborators, and there's many of you here. We love you. You're going to collaborate. You go right with what we want with team science. You embrace challenge. You're realists. And so I think as we try to get all these people working together, that has been one of the problems we have had, is that we all see the elephant at a different place. And so with this, we need to appreciate where we're all coming from. And similar is the technology piece. You know, your whole world is technology now. You know, you don't go without 5 minutes, without maybe 1 minute, without touching that cell phone or that BlackBerry or that computer. And I'm just as guilty. Mine's sitting right in my pocket. But if you look at who's using social network, which is important for patients in the future, online video, Twitter, you can see veterans not so much. Boomers were sort of doing better. Generation X and millennial, that's where they are. And the first thing my son did when he came back for spring break last week, he's in college, was to get his Xbox hooked up. I mean, that was his #1 thing, you know, electronics. Hello, Mom, going upstairs, you know. So part of it is to realize that's where they spend their time. And with this, unlike the veterans who worked in a company for 62 years. My father worked at the Chicago Tribune for years. My father-in-law was at General Motors for 82 years or something amazing. The millennials are going to change jobs, and so are the Gen X, not so much. And the boomers, I'm actually more like a millennial because I have changed jobs. But switching careers and changing jobs are the new group. So what were the plans? The 80-hour work week was to make a better work environment. I think that happened. Better supervision, that happened. There were many times when I trained, I was not supervised doing an operation, and therefore I was very autonomous, but also perhaps not supervised. And I think there's a real good balance, and we'll probably hear a bit about that from the panel. There was early detection of impairment of you all. We spend more time with you now. We can see if you're depressed. We can tell if there's something odd if you don't show up on work on time. We can tell if you're burnt out. When I was training, one of my third years was always late to work, and he frequently slept in the office. And he was a great guy. I couldn't diagnose it, but 2 years later when he was a fellow, it turned out he had a drug abuse problem. So I noticed, but my faculty didn't because we didn't spend enough time with him. And burnout also leads to dehumanizing effect, and we actually can look at that. We can see if you're cynical and decrease in your compassion, and we think we can help you deal with that as you go forward. Now, the 80-hour limit identified appropriate clinical pathways. We actually figured out what you needed to know and what you didn't. It developed this multidisciplinary team, which did not exist when I trained, where you utilized others to help take care of the patients. And we see that in many elements: nurse practitioners, physician assistants, hospitalists, and you're supervised much more. People have used nighttime floats, which we'll talk a little bit. And all of this, we do think, has led to a healthier physician. Now, the American College of Surgeons, where I'm chair of the Board of Regents this year and last year as well, I've been a regent now for 8 years, just came out with a peak performance fatigue statement. It was not for this lecture, but it just happened to come out for this. And it really is looking at fatigue on performance. And there is an effect when you're tired. And a lot of the studies have been looking at people that do very repetitive motion things, perhaps being on an assembly line or doing something that's monotonous. And if you're tired, you'll fall asleep or not do so well. Now, some of the things we do are monotonous and some things are rote, but frequently when you're tired, you're up delivering babies, you're doing a ruptured aneurysm, you're doing things that perhaps aren't monotonous but very intense, therefore you can do it, similar to those that do sporting events or some challenge to do that. And then, as you know, once it's all over, all of a sudden you have to pee, sleep, and eat, or eat, sleep, eat, and pee. You have to do all three at once. You do that. And then you go to bed. So it's a little different when you're a high performance person to do that. You can't imagine a NASCAR driver falling asleep going around that, but it is monotonous, but it's a little intense. So when you look at that, the fatigue piece does show that sometimes we have a prolonged reaction time. I do know I answered a phone twice and gave orders as an intern that I don't remember. I know that because there they were. Not quite sure remember doing it. And there is impaired decision making where you may actually be paused, and therefore it's very important to have supervision to do that. And you may not realize critical situations. And everybody varies. That's the other problem, just like competency in our response to fatigue. There's some people that need 8 hours of sleep. Some people need 5. And then you may have, depends on your workload. As you're a beginning intern, it's really tough. You're on this learning curve, and therefore fatigue may influence you much more than when you know what you're doing, where fatigue doesn't do it so much. And in objective testing, we often inaccurately assess our own ability to know, are we sleepy or not, because we really are intense in getting the work done. So the surgeon and institution share responsibility for preventing and addressing fatigue, and surgical professionalism, what we talked about at the beginning, requires surgeons and all physicians to acknowledge adverse effects of fatigue. You need to say, yes, when I'm tired, I probably won't be as good as when I'm not tired. You need to recognize and manage those adverse effects, and you have to be accountable for being physically and mentally prepared for what you do. I once had a resident show up on rounds, and he had taken this lovely vacation in a foreign land and had landed at 4 a.m. that morning and come right to work. What's that? That's not appropriate to come now be a participant as a professional when you took an all-nighter plane. I had another resident that once went to do a great giving back opportunity, but took an all-nighter the night before he took his oral general surgery boards. He flunked. Of course, he was exhausted as he went across. So some of these things you have to pay attention to make sure that works. And you have to, as an institution, establish support systems to address this. So fatigue-related incidents represent consequences of system failures. Therefore, institutions and departments, along with the individuals, are responsible for developing ability to do that. And we'll talk a bit about that because it is difficult. And each surgeon have to have an educational plan to look at this, whether it's asking you if you're fatigued, making sure call schedules look appropriate. We can tell when we see you whether or not you look disheveled or exhausted. In my previous position, every Monday morning, I either met with the interns, the second years, the third years, or fourth years, and we would rotate, and mainly I would just look at them, because I can tell by looking at you whether you're exhausted, tired, burnt out, and they thought they were learning from me. I was looking at them, okay, and that really is important. So I can tell. I had one resident once that looked bad, and he really looked gray, and I asked him, was he okay? And he said, well, my wife said I looked funny today too. And he went down to the emergency room, and his blood sugar was 600. That was nearly diabetes. So we're diagnostic people, right? So you can tell when you look at someone whether something's wrong with them or not. So now everybody will be nervous as I'm looking at you, but you can tell if someone's not feeling well to do that. And so you have to make sure that you have those abilities where people are paying attention to you, and the program directors will talk about that. And then you have to look at that. So again, it's all about the patient, and I can't wait to hear about the thoughts of who should operate on you. I once asked that question to my faculty, would you operate on a family member? I actually thought I knew that answer. Like, no, it's too emotional to somebody else, but well, what if I'm the best surgeon? Or what if it's an emergency? Or what if it's this? And I'm like, whoa. So everyone's got a different thing about who is that best surgeon. When my mother had her aneurysm done, I chose my partner to do it because that's just not something I do. But who is the best surgeon, at that time, and what is that choice? And then I think everyone understands this continuity of care, which we really worry about. A lot of patients would prefer you to re-explore them and drain the hematoma, even if you've been up all night because you did that operation yesterday. And others think maybe that's not the right thing to do. However, it's someone new coming in you don't know, and it's a bigger operation, maybe not so much. So we'll talk about that. So how do you decide if someone has fatigue or sleep loss? And what is impairment? And this is a physical or mental condition that makes you not be able to practice, that you're not able to give care, it's not safe, and you're not within your scope, because an intern's scope of practice is very different than a chief resident or a fellow or a young faculty member. So burnout. This I really want you to know about, because I learned a lot about this, and I'll give you a study. Because to me, we use the word I'm burned out, which means I need a sleep, I need a vacation, I need to go out to dinner, I need something different. But this is actually a self-reflection problem where you're almost getting too much input and you're having trouble dealing with it, and you're really feeling sort of depleted and negative, inadequate. And it's not just the night after you're on call. It's sort of like the way you are, and you continue to do this day after day and week after week. And this actually affects the way you treat patients, because they become inanimate objects. They become someone bothering you. It's someone that you go, oh, I have to go see this patient, and oh, there's someone in the emergency room. And sometimes you'll do that just because you're overwhelmed, but overall, when you go down and see that they're sick, you usually rev up because it's your responsibility. But this actually really affects how you treat others. And it's present in individuals who have constant pressure, and I think we all qualify for that, or stress over a long period of time. And again, you get this emotional exhaustion, lack of interest or enthusiasm for your work. You're physically exhausted. You find yourself going home and just going to sleep. And you treat everybody with depersonalization, where coworkers and patients are impersonal objects, and therefore you lack your sensitivity or your ability to say thank you, or say how are you today, or how was your day today, or what can I do to help this situation. And then you start thinking that maybe you're not accomplishing enough either, that you have a decreased sense of personal accomplishment. Work is not as meaningful or as important, and you actually become ineffective, and that's sort of when we start noticing it. So extreme consequences really affect the patient, so that's why it's so important. You may see adverse events when you do root cause analysis. Not infrequently, you'll see the people involved perhaps have been overworked, whether it's a nursing floor that has a high churn where patients are going through and the nurses are tired, or whether it's at the end of the shift, or whether it's a faculty member who's been very busy. You do see drug and alcohol addiction, and that was pretty frequent when I trained. I told you about the one with issues with drugs. We had a couple with alcohol issues. There were 2 residents that killed themselves during the time I trained at UCLA, and one in medicine and one in surgery. So even though we'll tell you those were the good old days of training, there were people that fell off the truck, and we don't talk about them much, and that was sad. And we do think by doing this, this will prevent that in you, but not so much. We also think you'll get married and never get divorced and have kids or have great relationships and nothing bad will happen, but that's not going to be true either, just because you sleep more and we're watching it. But we actually think you'll be able to handle it a bit better. You will see sleep disturbances, broken relationships, chronic diseases. You actually can get, tachycardia, or you can. I actually had one episode of atrial fibrillation when I was an intern. So did another guy, which is interesting. And people will retire early, be depressed or anxiety, and then we do see an increased risk of suicide. So the American College of Surgeons, we did this survey about 6 years ago looking at burnout. And this was not my idea. This really was Charles Balch, who's a surgical oncologist, who noted that especially women surgical oncologists had a higher incidence of depression and burnout. And therefore, we sent out a sample. We got 32% response rate. Mainly, they had worked in practice about 18 years, mainly private practitioners, worked about 60 hours a week, and were on call about 2 nights a week. And what did we find out about burnout? We used survey scores and tools that were documented to be effective for this, and about 40% fit criteria for burnout. They had high emotional exhaustion and high depersonalization, and I actually repeated this in my department, and the percentages were about the same. 30% screened positive for depression, and normally that should be 15%, and 28% had mental quality of life scores and physical quality of life scores that were below the norm. And 50% said they had a thought of taking their own life, 1 in 16 in the prior 12 months. This will get more positive as I go through, because it's like, oh my goodness, right? 74% would become a surgeon again, but those with burnout, much less. But look at those that were not. This recommending whether your child should be that, as if you could recommend to your child what they should do, which I haven't been successful with. As you can imagine, burnout was much less than those not. And the ones that were burnt out really felt they didn't have any time for their work-life balance and their families. When you looked at specialties and what kind of factors were associated, having young children and some of the specialties, as you can see here, have a little bit increased association. If you were really all your income based on billing was one that was high to do it. But it did appear that actually as you got older, the chances were a little bit less. Absence of burnout really does make you love what you do, so it goes hand in hand. You needed to have some time for non-patient activities because that was important. And whether or not you worked in the OR or had nights on call, that didn't seem to have much effect as the other things that you loved your life. When you looked at the women, which was interesting because there aren't as many women in my specialty as perhaps in yours these days, but now my applicant pool was about 50% women. But women and surgeons at that time were younger, less likely to be married, less likely to have gone through divorce, and less likely to have children, but they had twice as many had their spouse or partner working outside the home, and that's what leads to actually work-life balance when your partner is as busy as you are. And about a third of them were actually partnered with other surgeons, and of course that's a real problem when you have two people that are so busy. More women than men had burnout because of this, depressive symptoms, lower mental quality of life, but higher physical quality of life. And when we looked at who provided for sick children and children out of school, 25% of women relied on the spouse or partner, where 70% of the men did. So it was a different dynamic at home. Women felt child rearing slowed their career, showed a conflict with their spouse, and had experienced this work-home conflict where you had something at work, something at home, and you really need to pay attention to that so that you have enough help, whether it's family or hiring or whatever, so that you have coverage so this doesn't happen. So with this 40% burnout and depression, this mental quality of life, for leaders, we need to know about this because we actually need to give you tools for this personal family life. And the woman I do these studies with is an internal medicine doctor at Mayo Clinic, and she said those that take emergency call and do emergency operations and have intensity that you can't delay see more of this than physicians that perhaps are in clinic situations. However, as we go forward, if you do not have burnout, you do love your career. And burnout was the greatest predictor of surgeon satisfaction with career and specialty. And burnout affects the way we feel about ourselves. And these professional characteristics are all of you. You're younger, you have kids, night call, many of you have spouses working in healthcare. So we have to provide you tools to work with this and we have to understand it and be willing to talk. More women than men had that, but I think that's going to change because in the next 10 years there'll be equal numbers of men and women, and that we actually need to look at this work-home conflict, because that's the big deal, is that you need to provide opportunities so that doesn't occur. So what this did to all of us is that it really said personal wellness. And there's a great effort at UC Davis looking at this, and many of the departments, and you'll see this coming out of my office as well, is that we really need to understand it. The first thing is to understand it's there. Then you need to make sure we're much more healthy. And then we need to look at some research to really look at what can we do to help people, especially in younger ages, to be more effective. Leaders have to take responsibility for this, and I think that's where it comes from, is you need to hear me talk about it, your department directors, your chairs, your chiefs, and we need to really respect boundaries so that you have work, you have home, that we really take care of you and that you do better things. And by investing in this social capital, I'll see you be a physician for a long period of time. You'll stay here because it nurtures that, and you'll be one of our physicians for a great period of time, and it'll give a great partnership. So the power of a leadership is that you have to provide that direction and guide action. That's what we're doing today. We're going to give you stability in this uncertainty time because you're going, God, am I in burnout? Am I work life? What am I doing? We can help you do that. It actually gives you that bigger purpose, that meaning, which at your level, when you're young, it's just, can I get this done? Can I get through training? Can I get a job? Can I? You will get to a part where you're looking for meaning in your job, and we really want you to make sure you're available to do that. And enthusiasm and commitment, you'll see me very enthusiastic about what I do in this position, because being a physician and surgeon has been fabulous for me. It hasn't been fabulous every day, every week, all the time. I've told you stories about when I trained, and I can tell you stories when I went through my divorce, and I can tell you stories about changing jobs. I mean, it's not like it's been a slide to get here. It is a ladder. But you shouldn't be a mountain that people aren't helping you up. So the achievable future we need to show you is how to go forward, how to be passionate, how to have meaning for your life, and we'll have the panel talk about that. And residents make mistakes. You know that things happen. Attendings need to help us do this. We have to provide emotional support. You have to interpret their distress, and you really need to talk to residents. And I think that's what the 80-hour work week has really done, is actually increase communication between faculty and residents, chiefs and younger people, because you're all in it together. So one of the questions I ask faculty every day is, why do you come to work every day? And for residents, it's very simple. I have to come to work and train, right? But for faculty, it's really important because it changes. And so you need to make sure that 50% of what you're doing every day is what you really want to do. And if you don't come to work doing what you want to do, you're melancholy, and you won't be as good as other artists, because we actually are craftspeople. And just like poets and musicians, we will not accomplish it. So asking your faculty why do they come to work every day will actually allow them to have the best job. And you have to have work-life balance. You have to be organized. You have to employ others to help you. You have to keep a calendar. You may have to work part-time. I have many people that go in and out of part-time throughout my career so that they can manage their lives. And most importantly is all of you young people need a financial advisor. You should not be at my age wondering about money. You should have put money away. You should be able to be stable. What if I got sick tomorrow? Would I be able to stop working? The answer is yes, and so you need to make sure that happens, and having a financial advisor is very important. You need to have mentors. They're essential, and you need to have a committee, and we're working in that throughout the school, and you have to promote people and really make them feel part of the institution. So next steps, our jobs as academic leaders is to recognize all these factors, accommodate your needs. We're going to talk about that today, both men and women. And we have to do strategy in order to help you have a wonderful career as you go through the whole career and manage your problems, because all of you are going to have issues and problems. So I always end everything with a quote. This is my best one. I love is nice matters, that kindness in words create confidence. Kindness in thinking creates profoundness, and kindness in giving creates love. And I think throughout this, we need to be kind to each other so that we each can accomplish our goal.
So I'm going to start off with the beginning topics of Dr. Fleischach's talk, which was the 80 hours. Basically, residency itself is designed to train you to be competent physicians and surgeons at the end of training, regardless of the number of hours. I'm in the unique position of having trained in the unlimited hours period for the first half of my residency, and then the 80-hour limited time in the second half of my residency. And I continuously, over time, have recognized that the number of hours spent in the hospital, it doesn't equate to quantity of time, it's quality of time. When I started at UC Davis, a chief resident on trauma would spend 2 months in the hospital. They were allowed off Tuesday mornings and Saturday afternoons. Otherwise, they spent the rest of the time living at the hospital for 2 months. And basically, their amount of interaction with patients was about 10 minutes. They would pop in, see the patient, say everything looks okay, and go back to the call room. And it's really difficult to argue that the quality of that time had anything to do with the quantity of time that they spent at the hospital. Now, the problem that we do have in resident education is we have a public relations problem. If you looked at the slide where physicians feel that the 80 hours have negative impacts on resident education, we are portraying that message to our students and to our residents, that because you didn't spend 80 hours in the hospital, you are not well trained and not well competent when you go out. When in fact, I would argue that it's not a competency problem, it's a confidence problem. And I'll tell you, when I got done residency after training for 7 years as a surgeon and my critical care fellowship another year, I went out, and my first case that I did as a surgeon was in the middle of the South China Sea on an aircraft carrier, the USS Ronald Reagan, by myself. I'm the only surgeon for the carrier group, and I had a sailor show up in the office on the ship with testicular torsion, and I needed to do a bilateral orchiopexy. I'm going to tell you, I was competent. I certainly was not confident to be operating on a procedure that I had seen once as a resident. I knew what the steps were, but I certainly did not have the confidence, but I had the competence. So what we need to do for our residents is we really need to argue the fact that, yes, even though it is 80 hours or sometimes less, you still have the confidence, the competence and the confidence to go out and to do your practice. No one is going to feel 100% confident when they start working alone by yourself in practice, no matter how many hours you have. That is just a hurdle we have to get over as surgeons, as physicians, that we need to get over that confidence issue regardless. But you are competent. And really, like I said, it comes down to a public relations issue. The data supports that you are well trained in 80 hours as much as 120 or plus hours. But it is how you perceive your skills that's most important. So I'd like to thank you again for allowing me to be on the panel, and I will pass the microphone to Dr. Pate.
Okay, I have a statement. It feels so strange to be on a panel with these hardcore surgeons and a judge. Anyway, my job is to provide some perspective coming from the viewpoint of our unique field of obstetrics and gynecology. Perhaps not to the extent of general surgery or orthopedics residency training, but OBGYN residency is a very demanding one, and we certainly have to deal with the duty hour regulations. By and large, we've been able to be compliant with the regulations because we've instituted a day-night float service on labor and delivery. Labor and delivery lends itself very well to a day-night float shift service because it's kind of like a mini ER for pregnant ladies. And so it functions kind of like the emergency department, of course on a smaller scale. Having gone through residency when there were no duty hour restrictions, we would be on labor and delivery for 36 to 40 hours when we were on call, and some of the faculty felt that that was a good thing because then you had the same residents on labor and delivery continuously for 36 hours and there weren't as many sign-outs. But I think that as long as you have a very effective sign-out where you sign out all the pertinent information and to-do items to the oncoming team, that that the day-night float services work very well together. And there is a lot of continuity for the day-night float services. They get to know the antepartum patients very well. The night float team may deliver a patient that they admitted the night before. So there is a lot of continuity for our patients. The other thing that I've seen is much more accepted and acceptable to actually sign things out. You know, in the old sign-outs, if you actually signed something out to the oncoming team, you were considered the weakest, laziest resident that ever lived. I mean, it's like everything had to be done, and the oncoming team were supposed to have nothing to do. But the fact that it's more acceptable to actually sign out to-do items, I think that that is, that we're getting used to this new paradigm, and I think that's a good thing. The rule about should be 10 hours off, must be 8, that's a difficult one for our program. Because if you have a resident who's on GYN oncology operating late, and they have to get up the next morning early to round, sometimes that's a difficult thing. And none of our residents want to leave the OR to go home and rest. I mean, that is not something that anybody wants to do. So that makes it that challenging. The other thing about the ACGME 2011 regulations further limiting duty hours to 16 hours maximum for the interns, that's been quite unpopular in our residency program. We're compliant with the regulations, but that means that because we only have 6 residents a year, someone always has to cover. So having a nice weekend off or having a nice day off is very difficult. Another point I wanted to make was that because of these duty hour regulations, a lot of our faculty, and not necessarily here at UC Davis, feel that the residents are not sufficiently trained. They sometimes feel like they're shirking their responsibilities. They feel that, as in every generation, they worked harder than our residents do. But I think that, and as a result of that, I hear sometimes that our residents are not allowed to do as much in the OR. So they're allowed to assist and observe, but not do as much. And so that is a thing that we deal with. And then the last thing I want to talk about is efficiency, which is that I think most of our residents don't want to sign a lot of things to the next team. They want to get it all done. They have actually a very limited amount of time to get everything done. So they have to be much more efficient with the time that they have. So that's different, because when we were residents, we had all day long and all night long and all the next day to get all of our work done. But these guys have a very limited time in which to do that. And then lastly, I want to just be perfectly honest and say that, you know, I think a lot of faculty feel a little envious of the duty hour restrictions, maybe. Certainly our lives are much more sane than the lives of our residents, but I think that we don't have duty hour restrictions ourselves. You know, we work post-call, we have to stay until the case goes along no matter what. So I think there's a little bit of tension in that we have to be honest with our feelings.
I kind of, just where I'm coming from, so I'm about the same generation as Dr. Freischlag. So we had no duty hour restrictions when I was a resident, and I think that the glory days of medicine really were not so glorious. We would work a lot of kind of overnight shifts, work the whole day the next day. We were not really learning. We were just holding on by a thread. I say that we didn't work smarter. We worked pretty stupid hours. Things that I learned that to sleep anywhere at red lights, at stop signs on Lakeshore Drive. I learned to fall asleep between L stops if I was taking the train. And I learned to sleep in the OR standing up. That was a very good skill to have. Believe me, I was not learning a lot. So a lot of the things from the old days were not so great. We actually look forward to being on call and operating at night, because during the day, so many things that generationally were present are still present. The attendings who don't let you touch the knife and are really not that committed to teaching. As a program director, that's kind of one of my challenges. We would love to be on call at night, because our attendings would never come in at night. During the day, you were a boy. At night, you were the man. Go to it, Ro. You can do it. And I believe me, I had, so there were some things that happened that are good bar discussions, like residents doing a case and calling the attending in the middle of the case saying, "Can you please come in?" And the answer would be, "You can do it." Okay, just do it, Nike. I've had a lot of discussions with my father-in-law, who is a commercial airline pilot, now retired. I mean, a pilot can fly a plane, can fly 12 hours legally. It may take longer than 12 hours to fly 12 hours in a day, and after that, they're illegal. So the aviation industry has some safety features built in that we don't have. Joe is part of the military, and the military pilots can fly longer missions. If they're going to fly long missions, they get methamphetamines, which are administered and then taken back, and it's monitored. So I've talked to some of the military flight surgeons who are applying to our orthopedic residency. So that's a big part of their job, is monitoring those pilots who are given their drugs so they can stay awake. Personally, I think it's okay to work a 24-hour shift. But if you've really had 24 hours of wakefulness, you're really not that good the next day. And I think the principles of professionalism tell us that, yeah, you have to drag yourself out of bed in the middle of the night to take care of patients. We do that to our patients. But if you are not at your prime and you're fatigued, you really shouldn't inflict yourself surgically upon another patient. And I have been in the position to cancel surgeries. I've taken level 1 call prior to coming to UC Davis in an environment where it was just me on call all night, admitting, doing reductions, open tibias in the middle of the night. We didn't have urgent rooms. And I've canceled cases in the past because, your surgery's elective. I'm not at my best, and we should probably do this another day. I think patients understand that. It's a very, very hard thing to auto-regulate because in medicine, the culture is such that showing any sign of fatigue or inability to do your job is a sign of weakness. So it's not very popular. And probably I get more static from the residents who say, well, we shouldn't go to more restricted hours because they really want to immerse themselves in medicine and learn how to do the job. And I hope we can continue to provide, world-class educational experience with rules that sometimes we have to bend, rules sometimes we need to inform, but really to instill a culture of safety amongst the next generation of physicians.
I wasn't burned out as a judge because I retired, went to Hawaii for 2 weeks, came back and started a new job right away as a private judge, which is a good indication, I think, of how you feel. Almost 90% of you answered the question about informing a patient whether or not you are extremely tired, whether you've been up a long time, was not required and not a good idea, and that's really what I want to address. About a month ago, I was sitting in the waiting room in the hospital here while my wife had surgery for a broken foot. And at the time, I had had my assignments from Don Faggio, and I was reading articles on this idea of informed consent and whether or not a doctor should tell a patient that he or she has been up for 24 hours and may not be at their best. And we know that you're not at your best when you've been up that long. We've seen the report from the American College of Surgeons, and there are many others, about how you're simply not as good as you normally would be. Your reaction time is down, your judgment is down, and so forth. There's two articles that I was reading, one by a doctor, I think it's pronounced Chrysler, another Pellegrini, and Chrysler said, yes, you've got to inform patients when you are tired because the likelihood of bad results is just as likely as if you were intoxicated. And certainly you'd have to tell a patient that, and we're talking about elective surgery. And Dr. Pellegrini thought that would be inhumane to take a vulnerable patient at that time and say, oh, I am pretty tired, you want me to go ahead? And I really sympathize with that because I was going through that through my wife, and that was the last thing she would have wanted to have heard. Then as I got into it more and more, I started rethinking it a little bit. Because we know from all these studies that you're not at your best. And I'm convinced you will have numerous expert witnesses. Dr. Chrysler would be one, who is a national authority, that would be more than willing to come to court and say, this doctor who'd been up for 24 hours was not at their best. They were more likely to have a bad outcome, and therefore they should have told the patient that. Now, the other side is that's for the hospital, the individual, and the supervisor to regulate. And actually, I kind of prefer that on a personal and emotional level. But I might as well give you the bad news because this is a medical, legal program. The problem would be if let's take the easy hypothetical. The doctor who goes out at lunch, has several drinks, comes back and realizes that she's intoxicated, and then is reminded of an elective surgery that afternoon. Tells the patient this, patient's disappointed, they reschedule it. Fails to tell the patient that, says, hey, I can handle it, I'll go ahead, I've been drunk many times, so I can go ahead and do this. Gets a bad outcome. All right, now you've got a situation where very likely a court would hear expert testimony about that, might well instruct the jury that this was a situation that at the minimum required informed consent. Any reasonable patient would want to be told about this impairment. You did not tell them that. They did not consent. It's a medical battery. All of a sudden, many of the protections that are available to doctors and to nobody else in the civil justice system, such as a limitation on non-economic damages. If you have a malpractice lawsuit, the patient, the plaintiff, will be asking for compensation for their medical bills, compensation for their lost income, things like that, and compensation for the pain and suffering they've gone through. In California, that cannot, at the moment, exceed $250,000. It's been that way for 30 years. But that limitation would apply to a case of negligence, not a case of an intentional battery or a medical battery. It may well be that your insurance coverage wouldn't apply. Now, these are horror stories, but they are not horribly far-fetched. And it's something to keep in mind. And I would go back to what everybody's been saying here, that you need to be careful about it. You need to realize that you're impaired. And at some level, you need to think about talking to the patient about how you are and how you feel in order to get their consent.
So what systems should be in place to address faculty who are appearing fatigued, burned out, to residents and staff? That's one question, or vice versa, I guess, to residents as well. And how do we do that? Claire, are you looking for fatigue and burnout appearance? How do we do that besides me just looking at you every Monday? You know, that's one option to do it.
Yeah, I think that now that you tell me that you actually look at the residents, I'm going to start doing that now. Of course, I'm always the one that looks the most tired in the room, so I shouldn't judge. So I think that is an important issue. I mean, recently we had an issue with at M&M's. We openly discussed a blood transfusion order for another patient, and I specifically asked if fatigue had anything to do with it. So, and I usually do the sleep education every year, so I am definitely interested in fatigue and sleep deprivation in our residents, and I think it's an important thing to look out for.
Great. Joe, any thoughts about that? And hot off the press one is there any objective predictors of performance related to fatigue, other than just hours off? I mean, there are other things we can do besides making sure, because just because you're off doesn't mean they're sleeping. You know, they actually could be doing other things. That's the other thing. They could have a sick child at home that keeps you up all night, and then you come back to work, or like the resident I mentioned who came back from an international trip, 2 hours before his shift, or they could be out having a great time in downtown Sacramento, right?
Well, as a resident, as a resident, you always have that choice when you're done work. I can either go have fun or I can sleep. And 9 times out of 10, sometimes when you, especially as a junior resident, have fun always won out over sleep. And
that actually may prevent burnout. I mean, so part of this, have fun, it may be good to go have fun and maybe not go to sleep for 12 hours. I think as an institution, we do an excellent job at educating the residents, both at the residency level and at the institutional level, of recognition of fatigue in themselves and methods to combat it. I think what you really need to be able to have 100% capture of recognizing fatigue is to inform and educate the team structure to be able to recognize
fatigue and have mechanisms to offload residents when they are fatigued. Because the cause of the fatigue is kind of secondary. Really what you want is when they show up to work, if they're fatigued, do other team members, do attendings, does the institution have a mechanism to recognize that, and in a non-judgmental way be able to offload them of responsibility in order for them to get adequate rest. So one, they can primarily provide patient care, but number two, they can appropriately participate in educational activities. State-dependent learning, and as being someone that's fatigued, is very detrimental to the overall goals of residency, which is to establish competency. If you're always fatigued and you have that state-dependent learning, you're not going to function as well unless you are fatigued again. So I think it's a systematic team concept that has to recognize the fatigue.
So Orlando, as you're dealing with this fatigue and you're doing these tactics, what happens to continuity of care? And maybe you can reflect that as a physician and the judge can do that as a patient or a patient advocate. Does it matter that when someone, you change doctors during labor? Does it matter when you say, my partner can do this case, not me? Where does continuity of care go? And are residents paying attention to continuity of care as they go in and out?
So that's a lot of questions.
Yeah, you can choose any of them.
You cannot address labor.
I know nothing about that part of the body or that area of medicine.
Right.
But I think, number one, quality of life in orthopedics is pretty good, and I don't worry about the staff too much. If the staff are overworking themselves, it's mostly self-inflicted, that they just book their cases like crazy, and they put a lot of strain in the system. I mean, I think the residents are very, very good about taking care of patients, and really the surgical cliche or pattern of, they don't tend to get scrubbed out of cases in the middle of a case. So they'll see a patient surgical outcome to the end. They probably break the work hours, but I think.
But it's an average, so they can actually go make up it later, right? To do it.
Yeah, I mean, I do think that that the residents work harder than most of our staff, and they really are dedicated towards learning the craft of surgery. So I don't have too many fears or worries about our program particularly.
So how about as a picture of a patient or a patient advocate? If that had happened to your wife's foot, or when someone came in to fix my kid's collarbone, how do you feel?
I'll give you my recent perception on it. First of all, from a legal perspective, it would obviously be better to have a competent replacement than an exhausted doctor who was the current doctor. But from the patient's perspective, even the way the procedure works normally, where the patient is in the waiting room, the resident comes in and talks to the patient and tells them A, B, and C, and then the big doctor comes in, the specialist, and he tells them X, Y, Z. And it happens with some frequency, and it drives the patient crazy. Even though they probably don't express it. Well, the first doctor said this, the second doctor said that. What am I to believe? What am I going to do? It's very anxiety producing, just that. Switching doctors would also increase anxiety. But, putting aside the nurturing husband role and going back to the judge role, I certainly would recommend that over the exhausted doctor.
So for each of the panelists, how do you assess your fatigue? If you were to tell us personally how you make that happen, and what lessons learned would you tell people in the audience about that? Maybe Orlando, do you ever get tired? And how do you assess that?
Well, yeah, I do get tired, but I am a caffeine addict. I know that NOS has 240 milligrams of caffeine. Monster has 200 milligrams. A cup of coffee has 60. I start my day with a double espresso every day, pretty much. So, I mean, I am a pretty efficient sleeper. I can recharge after a couple hours, and I think that you only know your limit until you've pushed yourself to the limit, and when you've gone too far. So, I mean, I think So I don't know. It's a very personal issue, and there's a lot of physiologic variability. We've had residents in our program who routinely sleep 2 or 3 hours a night only, and that they thrive on that. So it's all very personal.
So Claire, your insight into your fatigue?
Yeah, I think that I'm one of those people, I need a lot of sleep. I knew that because when I had my one daughter, I've never been so sleep deprived in all of my life. I think I would do OBGYN residency pre-80-hour work week 3 times over before having to suffer the sleep deprivation of maternity leave. So, so I think that is, I think that the ongoing night after night of no sleep, the chronic fatigue, I think is most important. And I think for me, I think we're all, pretty much can say that we're tired all of the time, but I think the 2 times I remember in residency when I really knew that I needed sleep and that it was really impairing my work was when I was assisting in the OR after being sleep deprived the night before. Assisting in the OR it's just kind of, you're not doing the operation. So I remember specifically helping a GYN oncologist with periaortic lymph node dissection, and I was the one retracting. And I was doing what Ro was doing. I was trying to sleep while I was retracting, and it could have been a disaster. So those types of situations, I think, are you just have to recognize that I can't assist you. But during that time in residency, you couldn't tell the attending that I'm too sleepy, I can't assist you. But now I think it's much more acceptable to do that. So I think that is very important to say, okay, I'm so sleepy, I can't even assist, or I can't do this. And then the other time is like writing, when we didn't pre-electronic medical record, when you're like writing a progress note and in the morning and your pen's going off the page, every single line, and you can't even write a note in a decent amount of time. It's like, you're sleep deprived. So I think when I recognize it in residence is like, for instance, if I'm giving a didactic lecture and I'm such a dynamic speaker, but they're all having micro sleeps, I'm thinking, okay, they're probably sleep deprived, and it's not just me. And
they all
giving
were
the
awake
boring
today.
lecture.
Everybody was awake.
Yeah, exactly. Micro sleeps, I think, are something to look out for. And then just when you're looking at someone assisting you in the OR and they're micro sleeping, I think that's an important alert.
Yeah, Joe, quickly, and then the judge.
I think it goes back to, we all have the stories of waking up in someone's chart with drool on the page and saying that's probably a little too much. But it goes back to what Dr. Roberto said, is you have to kind of see where that threshold is for you. Everyone's threshold's a little bit different. I served in Afghanistan. I knew I was exhausted at times doing cases. But I developed a system of, I know I'm getting tired. This case is more difficult than it should be, and I opt out of the case. I don't do the vascular repair. I quick put a shunt in. I go sleep for 5 or 6 hours. I come back, and the case is a breeze after that. Same thing with my practice here. If I have urgent cases that I can only do at 2 o'clock in the morning, and it's a lap chole, forget that. I'm going to have to wait till the morning because the case is going to be safer, it's going to be quicker, it's going to be more effective, because I know what it's like to try to do a lap chole at 3 o'clock in the morning, and I know what it's like to do it at 8. And the 8 o'clock ones, regardless of patient severity of disease, they always go easier, they always go smoother, and they have less complications. And you have to get to that for yourself to see what that level actually is.
Fred, last comment.
Well, when I was a trial judge, I can relate to Claire's idea that you're taking notes of the case and your pen starts to fall off the paper. And it's not a good idea for a judge to appear to be sleeping in front of the jury. It's very bad for your public relations. But you have the advantage that you're in charge. So one, you could stand up. It's a seating job, so you're sitting. You could stand up, or you could take a break and get coffee and so forth. But nowadays, I think the best solution is the power nap. But now you're usually not in a position where you can do that. Right. When you're working in an office, you can do that. Nothing better to get you going again than a 10-minute nap. People still look down on that, even though it's a lot smarter than sitting there for 2 hours doing nothing, trying to stay awake.
Right. So I think what we learn from that is self-reflection. You know, you need to know yourself. And as I've aged, it's different when I was 20 and 30 being up all night than now that I'm in my 50s. And I think that's the other thing. Age really will change you about how much sleep you need, when you need the sleep. Are you a napper? I'm certainly, my son got my gene, which I can sleep anywhere, anytime, which maybe is from general surgery residency. I'm on a plane out for 2 hours. It's just great to do it. I'll finish 2 or 3 little questions. I really appreciate the panel. One question, is there a medical culture difference between East Coast and West Coast? That's a whole lecture, but the answer is no. Okay, I actually think that there's more similarities on East and West Coast, and I've even been in the Midwest, and I think part of it is the rules have actually embraced us and made us more similar, but we could talk about it. Weather is really bad on the East Coast, and that changes a lot of people's lives. The other question is the opposite of depression is vitality, and I think asking, should people that are depressed practice? I think with treatment and taking care of people they can, I think vitality is important. And last was, yes, we do need on-site child care, and that's on my list to the chancellor, and I am working on that. Everybody's agreed. I'm not sure when and where or how, but I can't even imagine having used child care at Milwaukee across the street. So that's on my list, as well as a larger, bigger rec center. And it may not be tomorrow, but we're going to work on those, because I think those both help burnout and also help taking care of what you need to do. So I want to thank the wonderful panel for their questions. And I want to thank all of you for your questions as well, too. And what I'd like you to do is to go forward and do good things. Talk about this. You know, talk to your faculty, talk to each other, power nap, tell us what you're doing, make sure you don't get burnt out. Think about those things, because a couple of you may actually feel, maybe I am burnt out, maybe I am a little depersonalized. So make sure you have those conversations. And I want to thank you endlessly.